Hello everyone. This video will demonstrate a very safe and fast technique to manage soft cataracts. Now this is a grade 1 to 2 nuclear sclerosis with a posterior subcapsular cataract. This is a young patient planned for a multifocal IUL. Sometimes tackling these soft cataracts is harder than tackling hard cataracts because the conventional techniques like divide and conquer, direct chop, they don't work very well in such types of cataracts. So after staining the capsule, I fill the anterior chamber with viscoelastic. Now I will be doing the capsulorhexis. Now two steps are most critical in this technique. First is making an adequate sized rhexis. If you make a small rhexis, you will struggle. So always make at least a 5 millimeter rhexis in all cases, especially in very soft and very hard cataracts. So here I struggled a bit in trying to make this capsulorhexis perfectly circular, but it came out okay. It was just about 5 to 5.5 millimeter in size rhexis. The second important step is a good hydrodissection and hydrodelineation. Take out the viscoelastic and take this cannula just underneath the rhexis margin and inject small amounts of fluid in multiple directions. Now your aim should be to gradually pop out this nucleus out from the capsular bag. You can repeat hydrodissection in other directions as well. Now here you see the fluid wave brings up the endonucleus slightly anteriorly. Now again recoat the endothelium with a dispersive viscoelastic and make a side port. Now these type of soft nuclei, they do not crack or they are very difficult to chop also. So best is to eat them up only with aspiration and minimal power outside the capsular bag. Just tilt it, impale with the phaco tip. You can chop them into some pieces and then gradually emulsify it. So this is a very easy and a fast and a safe way to handle these type of cases. So within seconds the nucleus is out. And now we are left with the epinuclear shell and the cortex. Now we can try to take this epinuclear shell out with the phaco probe itself, but I feel the irrigation aspiration probe or the Simcoe cannula is safer. I am making a side port inferiorly for the subincisional cortex, and I will be using a Simcoe cannula to aspirate this epinuclear sheet and the cortex. Now in these soft nuclei, taking out the epinucleus sometimes takes more time than doing the phaco part. Gradually peel off the epinucleus out from the capsular bag, bring it in the center and aspirate. Now I find Simcoe very controlled, so you can use the bimanual or coaxial IA also, but Simcoe is also a very good instrument. So now all the cortex is out. Now I fill the capsular bag and the anterior chamber with viscoelastic, and in this case I am implanting a multifocal intraocular lens. This is a 2.2 millimeter incision, a wound assisted delivery. The leading haptic also opens outside the capsular bag, so I'll use viscoelastic to gradually push both the haptics downwards and slightly rotate them so that they go below the rhexis inside the capsular bag. Now these hydrophilic lenses are very flexible, so you can just inject visco and push them with the cannula and they will fold and go inside the bag. I inject pilocarpine and then again I take Simcoe to wash the viscoelastic thoroughly. It is very important to clean all the viscoelastic from the eye. You can also go behind the IOL, or the other option is you can tap the IOL gently and the viscoelastic from behind comes up and then you can aspirate. It's also important to clean the viscoelastic from the anterior chamber and the angles, especially in these multifocal IOLs. So you tap the optic and all the viscoelastic comes up and you can then aspirate. So this video demonstrated a very fast and a safe way to manage soft grade 1 to 2 cataracts, in which the conventional techniques of divide and conquer and chop, nuclear chop, are difficult. And instead of struggling with those, you can just make an adequate sized rhexis, do a very good hydro, bring out the soft endonucleus out of the bag and aspirate in the pupillary plane. Thank you for watching.